you know, are we in a new dawn of kind of thinking about how we design clinical trials? And I wanted to go back to Heather because we made this approach before, just kind of thinking about the third generation EGFR TKIs, much more mutation specific. Maybe they're better first,
right?
Maybe they're not. And just kind of thinking about, you know, one of the advantages we had in lung cancer historically is it didn't take us long to get an answer because of the population. But now in this population where the median survival now is 3 years in that range, sequencing studies are going to take a lot of time to do. Thoughts?
Well, I think we still have to do them. What I think is good is that we were able to get EGFR TKIs and ALK drugs approved based on response in PFS without dealing with the overall survival issue, which as patients are living a longer time, so many other things can happen with them that's going to dilute out whatever effect it was of your initial drug. And so I think we've learned that we don't necessarily have to see that overall survival difference if we have a robust enough response to a particular agent. And we can also look at PFS. So that's going to come in with sequencing. So with the new EGFR TKIs like ruxolitinib and AZD9291, as we've talked about earlier, those drugs are both very, very well tolerated. With the AZD9291, there's a little bit of rash, a little bit of diarrhea, occasionally some lung effect, just as you see with the first and second generation EGFR TKIs, but much less. With ruxolitinib, we're not seeing as much of those toxicities. There's an unusual hyperglycemia that we are seeing that surprised us in the phase 1 because it was not seen in any of the preclinical work, and because it's a metabolite that only happens in humans and not in other animals. Now that we recognize that, we're able to easily manage it. A lot of the patients are on metformin, and we can discuss that as a whole separate topic as to whether or not that's beneficial, right? To be able to keep that under control. So these drugs are now looking perhaps even better tolerated than our first generation EGFR TKIs. And so that brings in the question of, well, where do we give them? So they've all been looked at after resistance develops, but if we can use them to prevent resistance for a longer period of time, that's theoretically much better. And so both of those drugs are in first-line trials compared to standard first-line EGFR TKIs. And with ALK, it's the same idea. All the new ALK drugs are being looked at initially sort of in the, well, how can we make them work after crizotinib? We're seeing lots of activity there, so now they're all being used first. And so the studies are hopefully going to give us those answers about the sequencing. And when I meet with a patient who's got EGFR ALK and I talk with them about treatment and I get asked a question, well, why can't I get on this drug first? Right. We talk about, I like to use the analogy sort of, well, it's kind of a marathon. If you sprint at the beginning, that doesn't necessarily get you all the way to the finish line. And what is the finish line? Well, we'd like to push that out as far as possible. Maybe we're, hopefully get into ultramarathon type of situations. And so it's how do we use what we have that's going to be effective with the least toxicity to then get you to the next thing that's going to be effective with the least toxicity until we figure out, and maybe that's where immunotherapy is going to play a role with other combinations, how to start at the beginning with something that's going to totally wipe it out.
Yeah. It's interesting, just kind of sticking with these in this setting. I think all of us were very impressed at ASCO and other meetings with the activity of these two new third-generation agents. Is one better than the other?
We have no way of saying that. I think if you look, the patient populations have been fairly similar. When you look at what are the absolute response rates, they're very, very similar, looking in the T790M negative versus positive. And with the fact that they're still phase 1, 2 type of data, those response rates are going to fluctuate around, but they're very, very close to each other. PFS, we don't really know what that's going to be either, and OS, we don't really know. So I really don't think we can distinguish them. They have slightly different toxicity profiles. Is it worth doing a head-to-head? I don't know. I'm not sure that I think so. I think it's more important that we figure out overall sequencing for patients, and the question of whether inhibiting T790M first line is better than waiting until it becomes more of a predominant factor. That's a really key question.
And I think that given the level of activity of both of these drugs, the toxicity is really not an issue for me. The whole glucose intolerance thing is managed.
It's manageable.
And, it's not a deal breaker in any way, shape, or form. Any other thoughts about the third generation TKIs? Roy, what are your thoughts about trial design? But I guess I'll ask you, let's switch to back to immunotherapy and talk about trial design there. We've talked a little bit about the biomarker situation. You know, we've seen a number of early phase 1 trials combining them with, you know, our temptation is to graft them onto carbotaxol or carbopemetrexate, and very small experience to date. Are these drugs best used maybe in a maintenance fashion, or what are your thoughts?
Well, all of the above. And my intuition is not to think about combining them with standard chemotherapy, though it needs to be tried. It's an important experiment. It will be done. I have been impressed by some of the, again, just phase 2 results, you know, with bevacizumab. I think there is something about bevacizumab that might help the immune response.
Mm-hmm.
But really, Mark, the thing that we need to do now is think about combinations with the small molecule TKIs. What better way to deal with the resistance than to have an immune response developing as the resistance developing,
Mm-hmm.
you know, in the median time of about, you know, a year. So that's certainly exciting with ALK and EGFR. Combinations with other agents that target the immune system, either co-stimulatory or co-inhibitory molecules. There are a whole bunch of these that are being looked at. You almost need to go back to medical school, you know, and you know, many of these were not, you know, of course, around when we went to medical school, even for the younger members of the panel. So the one thing that I've stressed to my group and with our collaborators is do it as, you know, we have to really be scientific. You know, we have a tendency in oncology to want to combine, be creative, and let's not lose that. But we really need to think about what makes sense. You know, why are these patients resistant? Primary resistance to immunotherapies, secondary resistance. You know, patients do, you know, recur. You have to do, as you do it longer, we all are seeing that. So what are those mechanisms? Get tissue, look at that tissue, and try to design, dare I say it, and battle trials for immunotherapy. We need to use the battle approach.
You're not allowed to use that word.
But you know, we need to get tissue, and you know, just as we did the battle, Ann and I worked together for a long time at MD Anderson. We get the battle trials now, looking at tumor and microenvironment, and trying to figure out how to do this. So I think it's the perfect area for us to all work in right now. It's great for patients. It's still not good enough. There's still toxicity. So trial designs with scientific endpoints, adaptive designs make some sense to me.
Absolutely.